Hello, students. This is Faizan Mirza. We are discussing the topic of immune system, the disorders associated with that, and the three main things that we are discussing here are inflammation, hypersensitivity, and autoimmunity. Our emphasis will be on inflammation and hypersensitivity mainly. So, what is inflammation? Inflammation basically occurs in a natural mechanism. Why is this occurring? Whenever a cell or a tissue encounters any injury, because of that injury, a complexly orchestrated response to that injury starts to occur. The basic aim of this inflammation or this cascade of events is to destroy the source of injury and remove the accumulated debris and initiate events that can cause repair of that injured tissue. So basically, inflammation aims to clear off the very cause that caused the inflammation to begin because of that certain injury. Now, this diagram figure 2.1 shows you the relationship between artery. You know that the blood goes into the artery and comes back through the vein or the venule. Between artery and vein or arteriole and the venule, there is a capillary bed. And this capillary bed, where the region where it joins with the arteriole, this region is called as there is a precapillary sphincter here. This precapillary sphincter controls the amount of blood coming into this circulation of this capillary bed. Blood circulation occurring through this capillary bed is referred to as microcirculation. This plays a very important role in the events which will be occurring during inflammation. We know that the capillaries are one cell thick, and these capillaries are having endothelial cell, and these endings of the endothelial cells are joined together to form an endothelial junction, and the edges of the endothelial cells, they form overlapping layer with the intercellular substances which have glycoproteins, they have proteoglycans there, and this gap is filled with these substances. So any exchange that occurs through the capillary will occur through this endothelial junction or through the endothelial cells of the capillary. When we are discussing inflammation, there are four cardinal signs of inflammation that were pointed out by Celsus in the first century AD. And these include rubor, tumor, calor, and dolor. And these are all Greek terms. Rubor refers to redness, tumor refers to swelling. This is not tumor, this is tumor. This refers to swelling. This is calor, refers to heat. Dolor refers to pain. So these are the four cardinal signs of inflammation, which means that where at the site of injury or any region where your body is having inflammation, these four cardinal signs will be occurring there. There will be redness, there will be swelling, there will be heat, there will be pain. You can just recall if you have had tonsillitis or some pain in the throat because of this, the inflamed tonsils. You must have seen, you must have observed the doctor looks for the redness in the throat, the swellings by feeling the tonsils with his or her fingers, palpating the tonsils in your neck region, and heat is produced. You feel when you swallow something that the throat region appears to be like hot, and then there is pain as well. The same goes for rhinitis, the inflammation, or sinusitis, or even the conjunctivitis. So itis is the suffix that is added to conditions wherever inflammation is occurred. Now, apart from these four cardinal signs, a fifth classical sign was added. So you call these as cardinal signs or classical signs. So these are the four cardinal signs or classical signs. A fifth classical sign was added by Virchow, and this was left referred to as functiolacia. Functiolacia is loss of function, which actually tells you that when the tissue, or when a particular region of the body is inflamed, not only it will undergo redness, swelling, heat, and pain, but it will be suffering from loss of inflammation, no loss of function as well. Now, the main features of inflammation involves accumulation of fluid and plasma at the affected area, the intravascular activation of the platelets, and polymorphonuclear neutrophils as inflammatory cells. Polymorphonuclear cells are the type of white blood cells which have a different nucleus, and the nucleus is lobed, or the nucleus can be indented depending on the type of white blood cell they are. First, we are discussing acute inflammation. You know, there can be the inflammation can be either acute or chronic. Acute is short term, and chronic is long lasting or persistent. So in acute inflammation, there are two events which are occurring: vascular events and the cellular events. Mainly, we'll be dealing with the vascular events. What happens in the vascular events? Vascular events means that the microvasculature, which means the arterioles, the capillary bed, and the venules, these are the earliest regions that respond to a tissue injury. Hemodynamic changes occur, and in these hemodynamic changes, the first change is that irrespective of the injury, the vascular response will be always a transient vasoconstriction of the arterioles. So the vasoconstriction occurs in the arterioles and from the site of injury, and the blood flow will be slowed down in that region, but within 3 to 5 seconds, or as long as about 5 minutes, the blood flow will be restored to not only normal but more than normal. Next, what follows is persistent progressive vasodilation. This occurs then, and because of vasodilation, it mainly involves arterioles. And as the arterioles start to dilate, more blood goes to that area, and this is why that region starts to appear red. This is followed by hydrostatic pressure, which start to get elevated. This causes transudation of the fluid into the extracellular space. The fluid that comes out of the capillaries into the extracellular space is called as exudate or tissue exudate. This starts to accumulate in the tissue spaces. What follows is slowing of or stasis. Microcirculation is you can say recruited. Blood starts to flow in them, but in the capillary bed. But since that plasma have leaked out, the blood viscosity in that region will be raised. Followed by this is stasis, and because of this stasis of slowing down, leukocytic migration margination starts to occur. Leukocytes, they marginate themselves together with the endothelial cells of the capillary. So the margined up white blood cells can actually move out of the capillary and go to the damaged site and remove the and resolve the signs which are of inflammation, or remove the injury site of it, remove the injury actually. So Lewis experiment. This experiment we do this in lab, but since the labs could not be conducted, so this is one lab we do this for for outlining how inflammation actually occurs. So Lewis experiment. This experiment deals with these three features: red line, flare, and wheel. These three are the features which are called the triple response. These triple response can be elicited if you run a blunt object on your forearm. This is your forearm. If you run a blunt object, which must have occurred somewhere in your life, or probably a nail or some sharp object which ran through your forearm or any part of your body, it would leave a red line, and then the red line will start to become flare, and then it would go to wheel. What is red line? Red line means it appears within a few seconds because of the stroking vasodilation of the capillaries occurred, because certain chemicals get released which cause vasodilation in that region. This is quickly followed by flare, which means that the region will start to appear reddish, and it will start to get diffused into that surrounding region. So the surrounding region starts to appear red as well. This is followed by wheal. In wheal, you feel the edema, and the surrounding skin starts to become, you can say, more swollen because of the transudation of the fluid, which is the exudate, which starts to accumulate. This is the same. This triple response is exactly what happens if you slap a person on face. So I give this example in class to make things more somehow more interesting and somehow more relatable. Figure 2.4 shows you passive dilation. This is normal vessel, normal capillary bed, but because of passive dilation, what happens? The capillary dilates and the venule dilates as well. This is why, because the arteriolar dilation occurs. So if the arteriole is not dilated, neither the capillary dilates nor the venule. But when the arteriolar dilation occurs, the capillary bed, the capillaries, they dilate, and the venule dilates as well. This figure 2.5, it shows to you this blood vessel, a capillary in a cross section. You can see that the red blood cells are flowing in the axial region. Axial means in the central stream. So when the blood is flowing through the vessel, the formed elements, your white blood cells, your red blood cells, they are all focused in the axial stream, which means in the center, and the plasma is flowing on the outer surface, or you can say the periphery of this flow, which is right in contact with the endothelial cell. These are the endothelial cells, and this is the basement membrane of the capillary. In between, you can see these are the endothelial junctions in through which the endothelial cells actually overlap. This is the normal feature of a capillary. But when capillary retraction have occurred, when the region is under inflammation, these capillary endothelial cells, they retract, and the gap between the endothelial cells, which is the endothelial junction, they widen. When they widen, the plasma which is just next to it, it starts to move out and starts to form exudate. Keep in mind that the plasma was already moving, was already traveling on the outer axis of this axial flow, and the formed elements, your white blood cell, your red blood cells, platelets, they were all in the central region of the bloodstream. So the chances of plasma leaking out and forming exudate are very high, given that the endothelial junctions, they widen their gaps. Serious inflammation occurs when there is basically a response to a mild injury in which only fluid is allowed to escape into in the extracellular spaces or between the cells. Only the fluid goes out. This is serious inflammation. A much more severe injury can cause a purulent, or you can say suppurative inflammation, in which pus actually forms and exudate goes out, and there are leukocytes involving neutrophils and a large number of other white blood cells, and the other cause of injury are also there. So this is called a suppurative. This is more, you can say, a bit of more severe kind of inflammation. At times there is diffuse, and as I told you, that pus also forms in suppurative inflammation. Pus formation is a characteristic feature of suppurative inflammation, which is a purulent or purulent is the other name for suppurative inflammation. These do not form in serious inflammation. In serious inflammation, there is no pus formation, just a watery fluid goes there. Then at times diffuse suppurative inflammation is also called as cellulitis. You might have heard this term before as well. An abscess form. Abscess means you must have seen that localized accumulation of pus that formed due to acne. And if that acne bursts, you see pus draining out and then blood coming out from it as well. So this is an abscess which forms. This abscess is the localized accumulation of pus which develops in that site where the injury occurred and where the white blood cells were constantly in a, you can say, a state of war with the causing causative agent of the injury. Then at times when inflammatory response has finally have removed the thread, a fluid filled sac called cyst, it stays there in that region, and this cyst is just a fluid filled space and fluid filled region. With time, eventually the cyst will diminish and the fluid will be reabsorbed into the surrounding tissues. At times there is hemorrhagic inflammation which is characterized by the presence of red blood cell. Keep that in mind. In inflammation, red blood cells so far did not go out into the exudate. It was just the plasma going out, and the white blood cells and the exudate had just these compound these components. And the red blood cells do not go out, but in hemorrhagic inflammation, red blood cells go out as well. We have to discuss leukocyte migration now. As I told you already, that the blood is flowing, the formed elements, they travel in the axial flow. Margination starts to occur at the site of injury inside the blood vessel. Margination means that once the fluid have leaked out, the white blood cells, they move from the axial flow and they start to marginate themselves. They start to align themselves towards the margin of the vascular endothelial lining. And once they have marginated themselves, they have aligned themselves with the endothelial cell, rolling starts to occur. They start to roll over that endothelial cell. Once they roll there, they pavement themselves. They pavement themselves. Pavementing means that they become flattened. They do not stay of the type of shape that they initially were. Pavementing means that they become flattened, just like pavement stones. Once they have become pavemented, they will become adhered to those endothelial cells, which means that they are just not going back to the axial flow. They will stay adhered until they allow transmigration. Until transmigration occur, transmigration means that now these white blood cells will squeeze out. You can see this in figure 2.1. This is rolling, pavementing, and margination, and this is how the white blood cells is squeezing out. When the white blood cells are squeezing out, there are various receptors and protein complexes which are forming. So these there are molecules such as selectins, intercellular addition molecule ICAM1, and vascular cell addition molecules VCAM1. These are present all on the endothelial lining of the capillary. When pavementing is occurring, these leukocytes, which actually have receptors for these particular molecules, they form complexes with them. They bind with these molecules, and when they bind with these molecules, they start to marginate, they start to roll, they start to pavement and adhere to those. When immigration is occurring, when transmigration is occurring, when the which means that the white blood cells are actually going out, this is also referred to as diapedesis, the movement of white blood cells out from the blood vessel into that damaged tissue, into the site of injury. This is also called as extravasation. So once these cells and these macrophages and the fluid have moved out in the exudate, white blood cell will not exist as the white blood cell as it was in blood. Now they are being called polymorphonucleosides. Polymorphonuclear cells are PMNs. They are multi-lobed cells. As I was talking to you initially. PMNs also include leukocyte. They include eosinophils and basophil mainly. They include neutrophils as well, and these are polymorphonucleosides. But then there are mononuclear lymphocytes as well, and these are actually not lymphocytes, these are monocytes. Monocytes are also a type of white blood cell, and when these monocytes they become part of the tissue, they become they turn into macrophages. Recognition and attachment is also something very important. Chemotaxis, as I had already discussed, that the white blood cell are going out into the site of injury, which means that there are some chemotactic factors pulling the white blood cell out from the blood vessel and into the tissue spaces. Then recognition and attachment basically means that opsonization occurred. There are molecules called as opsonins. Opsonins have high affinity for the foreign particles, foreign antigens. Opsonins attach to foreign antigens, and when they have attached, the opsonin coated particle become vulnerable to be caught up by a white blood cell. These were all the events, the vascular events and the cellular events of the acute inflammation. Now, if the inflammation is not acute, rather it's chronic, which means that the injury or the cause of that particular inflammation have persisted, that inflammation will become chronic. For example, tuberculosis itself is an example of chronic inflammation. So in chronic inflammation, the pathogenesis is a bit different. What happens? The white blood cells which go out, they stay out. What do you mean by they stay out? This experiment actually shows to you these white blood cells are spread out on the petri dish, and they have a large ability to just migrate and move about. But if you introduce a migration inhibition factor, MIF, if MIF is given to them, then white blood cell they will just not migrate from here. They will stay accumulated at the site where MIF is being secreted. So this is actually what happens. MIF is a type of lymphokine which is released in high quantity in chronic inflammation. So what happens in chronic inflammation? T helper cells they release lymphokines, and these T helper cells they release lymphokine which include MAF, which is macrophage activating factor. It calls a lot of macrophages into that region. I already told you macrophages are a type of monocyte which have become a part of that tissue now. So once macrophage activating factor is activated, macrophages come out and they stay there. They should have gone back, but they don't go back. Why? Because T helper cell also release another lymphokine, which is MIF, migration inhibitory factor. It inhibits the migration of macrophages back into the blood vessel. So these macrophages, they stay within the site where the injury occurred. So chronic inflammation is because the cause of injury is very much there, and the white blood cells are not going back into the blood vessel. The macrophages are staying within that tissue. When you classify chronic inflammation, they are classified on two patterns. Either it could be non-specific chronic inflammation, which is diffuse accumulation of macrophages and lymphocyte, which develops at the site of injury. Most of chronic inflammations are of this kind. But the second one is granulomatous inflammation, which includes an example of just the example that I gave you of tuberculosis. Granulomas form. Granuloma means these are specific masses that form, circular masses that form in the site of injury, and giant cells and multinucleate structures they start to form, and abscesses start to form in that region, which is very much characteristic of the progression of tuberculosis into stages in which it can become a source of compromising the life of a patient. Here in figure 2.10, this is the essential pathogenesis of the chronic inflammation. So let's suppose if the injury occurred, initially there will be an acute inflammation. If acute inflammation occurs, then antigen is cleared, healing proceeds, and resolution. Resolution refers to that the injury got resolved and the tissue function got restored. There is no functulasia anymore. But let's suppose if acute inflammation was unable to clear the antigen persists, or the repeat exposure, because for example because of smoking you keep on taking the same irritant again and again, so it scars the lung lining. So repeat exposure or the persistence of antigen, either it causes lymphokine release. I told you lymphokines are MIF or MAF, which cause the macrophages to accumulate and stay there. This could either cause chronic non-specific inflammation or chronic granulomatous inflammation. The next that we have to discuss are the four types of type of hypersensitivities: type 1, type 2, type 3, and type 4, and their associated autoimmune disorders, for example rheumatoid arthritis or systemic lupus erythematosus. So I'll go back to the other handout here, the which I passed on to you. This was of part A. The end of the that handout is having this slide in which we discuss the hypersensitivity, although it's related to immune system there, but we discuss it here because this is how the course is distributed into section A and B. But since we are teaching the whole course together, so let's discuss hypersensitivity here. So what's hypersensitivity? Hypersensitivity can be of four types: type 1, type 2, type 3, type 4. This is Coombe and Gell classification of hypersensitive reaction. They classified these into four different types. Type 1 is called IgE mediated hypersensitivity. Type 2 is IgG mediated cytotoxic hypersensitivity. Type 3 is immune complex mediated hypersensitivity, and type 4 is cell mediated hypersensitivity. The diagrams are very well summarized, and the description given below is something very concrete that can help you understanding the basics of these type of hypersensitive reaction. Hypersensitivity just means that your body, your white blood cell becomes evoked unnecessarily towards something which is not actually harmful. So IgE mediated hypersensitivity, this is type 1. What happens? There is an allergen, it binds to the Fc receptors. This Fc receptor is present on the surface of mast cells. Mast cells, once they attach this allergen, once the allergen attaches to this Fc receptor of the IgE or for IgE, what actually happens, this allergen is attached to the IgE, and Ig is attached to the Fc receptor on the mast cell. Mast cell undergoes degranulation. These are the granules. When these granules they become degranulated, they get removed from here, and they, when they go out in circulation, they cause several further chemical reactions to proceed. And among these granules, what these granules include, SRS, which is a slow reacting substance of anaphylaxis, SRSA, and their histamine as well. So this causes vasodilation, mucus secretion, bronchoconstriction, and itching in that region. This is because of the granules of the mast cell that got released in response to this IgE attaching to the allergen, and in turn attaching to the Fc receptors on the mast cell. Allergic rhinitis, asthma, hay fever are the examples of type 1 hypersensitivity. When we come back to type 2 is IgG mediated cytotoxic hypersensitivity. What happens here? Cells are destroyed by the bound antibody, either by the activation of the complement or cytotoxic T cells. So this is what happens here. The cell the complement activation occurred. This is for example erythroblastosis fetalis. You must have EBF, the disease which occurs in the second or the subsequent births in females. Okay, so this is type 2 hypersensitivity. What actually happens here, this could either be IgG or IgM. Cytotoxic reactions occur here. Complement system or natural killer cells become activated, and when they become activated, they can cause they can cause further problems and the chemical reactions to undergo the within the tissue and within the body. These examples include blood transfusion mainly. The most easiest example that you can keep in mind here is blood transfusion, when a person gets transfused with the wrong blood group. Type 3 hypersensitivity is immune complex mediated hypersensitivity. There are free floating immune complexes that cause activation of the white blood cell, and these deposit into the tissues. What happens here in type 3 immune complex forms, and these are antigen antibody complexes which deposit into the tissues. When they deposit into the tissues, they lead to abnormality in the tissues. For example, rheumatoid arthritis, in which the joints start to become inflamed, and the cells of the joints, they are replaced by non-functional cells, and this is how the joints are very painful to move. Rheumatoid arthritis, hemolytic anemia, or say hypersensitivity pneumonia, or SLE, systemic lupus erythematosus, in which deposits of antigen antibody complexes, they go on to deposit in various parts of the body, in skin and in joints, and this is a debilitating disease. Then we come to type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction, what happens here? Antigen attaches to the receptor here. This cell, this is a high T helper Th1 cell. This cell is called as a sensitized cell. Why is it called sensitized cell? Because this cell was already exposed to this antigen at one point in time, but it didn't react to at that point, but it became sensitized. When the same antigen comes on the second time, this already sensitized T helper cell, it calls for help from the activated macrophages. It releases cytokines, cytotoxic T cell become activated. And the most what actually happens here is that inflammatory cell, the when this is upon secondary exposure of the sensitized T cell with the antigen, as I told you, this caused the cytotoxic effects to be there. This example of contact dermatitis, which occurs due to, for example, if you are using some artificial jewelry, and that artificial jewelry start to sting at a point on your wrist or on your finger or any part of your body. So that's contact dermatitis, which means that the T cells became alarmed when you first when it came in contact with that particular thing or ornament on the first use. But on the second use, contact dermatitis occurred, reason being that the T cell was already sensitized to it. So these are the four types of main hypersensitive reactions which you need to discuss. So this sums up our topic of inflammation. That's it. Thank you so much.